of our audience members join us. Well, hi, everyone. Welcome. I'm Michael Morella, Managing Editor of Events at U.S. News and World Report. Advances in treatment have pushed the overall 5-year survival rate for children and adolescents with cancer to about 85%, as researchers and clinicians work to make that rate even higher and to broaden it for more types of cancer. Many are also working to improve the quality of life of cancer survivors and to mitigate some of the late and long-term side effects of certain cancer treatments. We're here today to explore how hospitals are supporting childhood cancer patients and survivors. We have a distinguished group of clinical leaders representing some of the U.S. News best children's hospitals for cancer who are with us today to help understand the state of survivorship and support for individuals and families at a number of stages along their care journeys. Our thanks to Children's Health for their support of today's program. Now, without further ado, I am pleased to introduce our group of speakers, who are Dr. Greg Armstrong, Chair of the Department of Epidemiology and Cancer Control and co-leader of the Cancer Control and Survivorship Program at St. Jude Children's Research Hospital. Dr. Karen Effinger, co-director of the Survivor Program at the Aflac Cancer and Blood Disorders Center at Children's Healthcare of Atlanta. And Dr. Ksenia Shlapsitsova, a pediatric hematologist and oncologist with the Cancer and Blood Disorders Program at Children's Health in Dallas and an assistant professor at UT Southwestern Medical Center. You can find their full bios along with video of today's event once we conclude at usnews.com/events. And please remember, for those of you with us live, we really do want to hear your questions later on during the session. Please share those in the Q&A feature on Zoom on your screen, and our team will review, and our moderator may give voice to them before we close out and the hour is up. With that, I'll turn the mic over to our moderator, U.S. News Senior Health Editor Shanley Chen, to lead the conversation. Over to you, Shanley.
Thank you, Michael. I am very excited to be here today with these illustrious experts to discuss one of the greatest success stories in modern medicine, the rise of childhood cancer survival. As Michael mentioned, cancer survival rates for children and adolescents is on the rise, but we've learned that the very therapies that save these young lives can carry significant long-term side effects. This poses a new challenge you all face when it comes to survivorship and quality of life. It's not just about adding new years to their lives, it's about adding life to those years as well. But before we get into our conversation, I'd love for each of our experts to tell the audience a little bit more about your roles at your institutions and the focus of your work and research. Dr. Effinger, would you mind starting us off?
Sure. I'm Karen Effinger. I am co-director of the Survivor Program in the Aflac Cancer and Blood Disorders Center, and the Kathleen B. Amos Chair of Cancer Survivorship. And I'm an associate professor of pediatrics at Emory University. I'm very proud of our program. We have about 2,300 survivors that we follow with 1,200 visits annually. And on my research hat, I really like to focus on care delivery and improving care delivery using technology, and also looking at transitions of care and health behaviors. I'm really excited to join. Thanks for having me.
Thank you so much. Dr. Shlapsitsova.
Thank you so much for organizing this exciting event. I'm excited to be part of it. I'm a pediatric hematologist oncologist at UT Southwestern and Children's Health. Clinically, I care for patients during active therapy, and I'm actively involved in supporting and advancing our large survivorship program. Like Dr. Effinger said, that Aflac Cancer Program and survivorship program is pretty large. It's similar to UT Southwestern as well. I also established and lead our multidisciplinary fertility preservation program. My research focuses on improving the quality of survivorship care with a particular emphasis on reproductive health and fertility-related issues faced by childhood, adolescent, and young adult cancer survivors. Again, I'm excited to be part of this panel discussion.
Thank you so much. And Dr. Armstrong, last but not least.
Yeah, thank you, Shanley. And Karen and Cindy, it's really an honor to do this with you. And so like them, I'm a physician scientist. I'm the chair of the Department of Epidemiology at St. Jude, and I lead really the largest long-term survivorship research study in the United States called the Childhood Cancer Survivor Study. So at St. Jude, what we really want to do, like Karen is doing, like Cindy is doing, is to complement great care with great research that's going to change care in the future. And so through the Childhood Cancer Survivor Study and our St. Jude Lifetime cohort, we're really doing a lot of that research in a collaborative way across other institutions. It's really becoming the headlights on the car for what we're going to do in care over the next couple of decades.
Absolutely. I'm very, very excited to have three of you here to talk to myself and our audience. So let's go ahead and get started with today's conversation. We're starting with some incredible momentum in your field. According to the latest American Cancer Society data, the 5-year survival rate for all cancers across all ages has climbed to 70%, which is up from just 50% 5 decades ago. In the pediatric world, that progress is even more profound, with survival rates for children and adolescents now reaching 85%, as Michael had mentioned. So, Dr. Armstrong, you're the PI for the NCI's Childhood Cancer Survivor Study. So let's start with you. With the pediatric cancer survival rate up to a historic high, what has been the most significant shift you've witnessed in how we approach survivorship compared to, say, 10 years ago?
Yeah, no, the landscape has changed over the last 10, 20, and 30 years, where if you go back to the 70s, we were grateful just that, roughly 58% were surviving, 60%. It was a fight. It's still a fight, but with that fight, we're at 85%. And that means most children diagnosed with cancer are going to become long-term survivors. So we have to now be in the mindset of children who will have chronic disease and chronic disease processes. And that's really not been the mindset if you go back a couple of decades. We were grateful just to beat the cancer. And still, unfortunately, I think in the lay public's eye, once a child survives cancer, I think they assume that they're fine. But the story of research, the story of those of us who do clinical care know full well there are a multitude of chronic health conditions and problems that they're at higher risk for in the coming years. Now, there's a number of sub-stories, but it'd be great to have Karen and Sinya sort of throw in their 2 cents on that.
Yeah, so I agree with you. Definition of success has clearly evolved over past few decades, and cure remains essential. There's no question about it, but it's not no longer sufficient on its own. And definitely, the bar has moved towards the ensuring high quality survivorship, helping patients live long lives, healthy and productive lives after cancer. In daily practice, this means thinking beyond remission to long-term physical health, reproductive health, psychosocial well-being, and overall quality of life from very beginning when patients are being diagnosed. And this is something that I feel like in the field is shifting towards that, but definitely more resources, more research, more support is needed to accommodate this high bar of having a successful survivorship, not only surviving, but also having productive and successful life after curing cancer.
Yeah, I agree with both of you. I think, one thing we've always used that 5-year metric, and I think now it's even more important to start looking at our 10-year survival and our 20-year survival, because we know for some of our patients, we can get them to that 5-year mark, but then they're having more disease relapse or unfortunately dying from some of the chronic diseases that happen after treatment that Greg and Senya were mentioning. So I think really thinking through what is 10 and 20 years down the road look like? And I agree with Senya. It also is something that now we're starting to bring up into upfront therapy. Like, how do we start from the very beginning, letting families know? Because one thing we see a lot in our patients is they don't want to hear anymore. They're done. They want to put it in the rearview mirror as well. But we know these things may occur, and we know that knowledge is power. And so how do we keep helping them become advocates for their own healthcare as they get older?
And Shanley, I would follow up on all these by saying, for the whole hour, the reason all this is important is this is our responsibility. The driving factor in these long-term health conditions is the treatment they received that beat their cancer. And that's what we discovered to beat their cancer, but it's also leading to the late effects. So we have a responsibility, especially as we move into the age of using novel therapies like immunotherapies. We have a responsibility to follow up and follow these patients for life and take care of them.
Absolutely. And talking about this responsibility that you all have to ensure the quality of life later on, not just making sure they're cancer free, but making sure that they can survive and thrive later on in all these years. And I'd love to contextualize it a little bit more for our audience because these chronic conditions are quite prominent, as you all had mentioned. I recall seeing a report, according to the 2025 AACR Pediatric Cancer Progress Report, that between 60% to 90% of childhood cancer survivors will develop at least one chronic health condition, from heart disease to secondary cancers, as a direct result of their treatments. And by age 50, I understand that these survivors face an average of 17 chronic conditions, nearly double that of their peers. So it's clear that, as you all have mentioned, curing the cancer is really only the first step. And there is such a new high bar of success and a new definition of a success that you have to go by. So my question for all of you is, what's being done at your institutions to support young cancer patients so they can not only survive cancer, but thrive in their later years as well?
I can start. I think we have been very lucky to have a lot of support for our childhood cancer survivor program. And I think that we would all be remiss to not mention the Children's Oncology Group has excellent long-term follow-up guidelines. And those, based on research, have really helped guide survivor care and what we need to do for screening. And really early detection and prevention are the things that we focus on a lot in our clinic. So we've been very lucky to have support. We have a multidisciplinary clinic. And I think one of the things that our clinic is really trying to do is how do we help to educate these patients and move things forward? And so we have different initiatives like Cancer Survivor Link, which is being run by Dr. Jordan Marchek at our center. That is a great resource for both education, but allowing patients to be able to share their health information with other providers. And I think educating other providers is going to be a key as well.
Yeah, I agree with that. At Children's Health, we're also lucky and fortunate, and at UT Southwestern that we have support from our programs to navigate through survivorship and have buy-in from institution to support large survivorship program. We have several efforts that I think worth highlighting. We have built a multidisciplinary fertility preservation program where every patient facing chemotherapy and/or radiation treatment receives an infertility risk assessment followed by individualized counseling and fertility preservation discussions when appropriate. And importantly, these conversations are revisited throughout the cancer journey and into survivorship. So that highlights the proactive approach to survivorship care is one of the examples. In survivorship, we also have multidisciplinary survivorship care clinic and developed a dedicated cardio-oncology clinic as one of the examples for patients at high risk of cardiovascular late effects that brings together oncology, cardiology with added support from psychology and nutrition. We also developed a robust survivorship database that highlights the opportunity that we have right now to leverage technology to help and have coordinated care for our survivors. That helped also to streamline transition to adult care, which I think is a really important topic in survivorship, especially when we're discussing childhood cancer survivors. And we partner closely with family medicine colleagues who are trained and invested in delivering long-term survivorship care. I think survivorship guidelines is important to highlight through Children's Oncology Group because this is a resource that available to all of us, including providers and patients' families and institutions that helps to streamline survivorship care. And more broadly, these efforts reflect a field-wide shift towards coordinated, risk-based, and longitudinal care that supports survivors well beyond the end of treatment. And I agree with Greg with the statement that this is our responsibility to ensure we take care of those patients beyond their treatment. Their journey does not stop when they complete their therapy. It continues, and we're obligated to support them through this process.
And then at St. Jude, we really have had a unique opportunity. And for now almost 20 years, we've looked at every survivor from our institution diagnosed between 1962 and 2012 and said, we'll bring you back for life. And that's not because every hospital ought to bring every patient back for life, every childhood cancer survivor, but because if we can do that with our population, we can learn from them. And again, provide the information that would be like the headlights on the car shining out in front of all of us to say, well, what does a 40-year-old survivor look like? What does a 50-year-old survivor look like? So we've really paired great clinical care with great research with that St. Jude Lifetime cohort. And so generating that knowledge is really important. But, the same issues are true with our patient population. They may be coming back every 5 years for a research exam, but someone has to provide their clinical care at home. So one of the keys that I know Karen and Cinia will want to talk more about, and we can only talk more about, is just transition. And we transition kids from our active clinic at 5 years to our survivorship clinic, but then they have to transition to the real world. And those transitions are really key. So it'd be good to hear from them how they're working on those transitions and what is working for them. And we can talk more about that.
Absolutely. And we'll definitely unpack the transition of care, coordinated care, as well as emerging technologies and the use of AI later on in our conversation. But I do want to ask you, you all have such a dedication and a passion for this responsibility and obligation to your patients, not just in that 5-year survival period, but in throughout the trajectory of their entire lives. So given the success that we're seeing now, this success of 85% survival rates, I imagine you all are very happy and are very excited at this trajectory of survivorship care. So, what excites you the most about where things are headed?
Well, what excites me the most is the day that we can say that a survivor has the same lifespan as someone in the general population, because that's still not the case, but we can get there. And so it isn't enough to survive. It's enough to, we want to have that long lifespan and long health span. So I think that's really where we want to aim for. So, for example, from research, one of the things we're learning which should impact how we think about these survivors, is that they are aging faster than you and I are. If they've been exposed to radiation and chemotherapy, they have an underlying biologic aging that is fast forward. And that's impacting a lot of things. So we've learned a lot from the research, and learning that ought to help us now tailor and target interventions that can slow down that aging process and help them live healthier long lifespans.
I absolutely agree with that. And what excites me the most, the ability to help those survivors beyond their treatment. So really be proactive at the time of diagnosis with some of the with use of cardioprotecting medications, with fertility preservation, as I mentioned, and then taking this through their lifespan and improving their quality of life. And it is definitely something that is exciting, and really being proactive and in delivering individualized care for those patients. And I do think also that this notion of helping survivors beyond their cancer treatment is really important. And I feel like we have a better understanding of those late effects because of the research efforts that ongoing, but also we are seeing better recognition of those issues in clinical care and in practices, and more resources allocated to help and navigate through the survivorship in care transitioning and when they get older. So I think it's moving in the right direction, but definitely there are many things that we need to work on to improve our delivery of care to cancer survivors.
And I'll just echo what Sonia and Greg said. I think there's a lot to be excited about. And I think the fact that now we are able to focus more too on people's mental health and how the quality of life, that we are not just looking at survival. But I agree with Greg that our goal really is to get them that they are living this long and healthy and productive life. And we know that our survivors currently are facing a lot more issues. I think it's also important now that we're starting to focus more on financial toxicity for our patients, and really understanding that it is a huge journey that these patients go through from a very early age, and that we're getting more supports around that. I think it's also very telling with the last COG survey that 96% of COG sites have some sort of survivorship care, and that continues to increase. And I think that's very important and needed across the country and across the world.
That's very, very exciting. And this transition from childhood to adult care, as you all have mentioned, is obviously such a critical piece. It's wonderful that people are living longer, fuller lives after cancer compared to, as you had mentioned, 10, 20 years ago. But there are those clinical and systemic ramifications of that care throughout their lifespan as well. Dr. Armstrong, I know you had touched on this a little bit, but I'm hoping you could expand on this. What are you seeing and learning at St. Jude, and that in terms of best practices and approaches for hospital systems to support that critical transition?
Yeah, well, there's a number of things, but I'll start with one of them that's important, which is survivor education, right? So while we have them in our survivorship clinics in that period of time, it is really time to empower those survivors, because they may be off on their own in the future and they may be their best advocate. And the hardest thing as a clinician is to get a few decades down the road and have a survivor come back with a major medical event in their 30s or 40s, breast cancer, stroke, something like that, and then say to us, I didn't know. I wish I had known. Or if I had known, I would have done my breast cancer screening. I would have, so that's the heartbreak in this is that we know because we've got the data, but then we get down to a survivor who's down the road and they tell us they don't know. So part of that starts with patient education and really spending time with our survivors in survivorship clinic. It can't be a 5-minute visit, right? We all know we've got to spend time in education. That's not always reimbursed well. It's not really incentivized, but we as clinicians have to fight for that time so we can truly educate.
Yeah, I absolutely agree with that, Greg. I think this is critical to spend time with those survivors, educate them. And for many of them, when they're diagnosed at young age, they don't remember those exposures. Their families and they lived through this cancer experience, but patients might not even remember what diagnosis they had, what treatments they received. So it's important to provide, empower them with this knowledge with hopes that they will be able to advocate for themselves in the future and will understand those late effects, like you mentioned. Comply with screening that is recommended, or for females, I take care of reproductive health issues. So for females, not to be able to have children only because they did not realize that there are implications to their future fertility as a result of their treatment. And really working through the ways to empower survivors is critical currently, and provide them with information and try to reach a receiving provider. But this is such a difficult to reach patient population sometimes because those patients are young, they move because of school, maybe life-related changes in their life. So sometimes it might be difficult to provide information to the receiving provider, but in empowering survivors with information and about their late effects is critical in my opinion. I absolutely agree with that.
Yeah, and I'll just echo the same, as heartbreaking as that is, I will say one of my prouder moments is when I had a patient call me and say, I saw the cardiologist and they told me that my heart disease currently was not due to my cancer therapy when I was a child, and I told them that they were wrong. And that is what we have learned that we have to do, because there's childhood cancer survivors, while it's a growing population, still compared to the US population is small. And it's been really challenging to be able to reach out to all of the adult colleagues that we need to understand. So really, this education of our patients is crucial. And so one of the things we've developed here is a very strategic transition plan for our patients. We have an age where we have to transition our patients, and so we work towards that plan starting at 14. And it's been eye-opening to know, because kind of what Senya said, when these patients are very young and they're treated, often they don't know. And I have been in a clinic where I didn't have somebody that at an age where we had to transition. And I saw 30-year-olds who were very, very, had their own kids, living their own life, and their parents were still making their survivorship appointments, because trying to help empower them in that one area is very challenging. And so I think continuing to work with our patients is crucial. And as Greg mentioned, a big thing is reimbursement for these providers, so that they are wanting to learn more and take care of our very complex patients.
Absolutely. And I definitely want to get to some of those challenges too, but I love what you had said, what you all had said about how this transition of care and educating your colleagues and working with your colleagues, that's a huge part of it, a critical aspect of that transition from childhood to adulthood. And it requires such a complex and a concerted effort for care coordination. As with all fields in medicine, as everybody knows, delivering quality care and improving patient outcomes requires that multidisciplinary approach and cross collaboration among different specialties and even patient and family advocates. So, as you all have mentioned, and especially to tackle that range of chronic conditions, everything from those cardiac issues and infertility, these children will face quite a number of issues. So, that transition and care coordination is without a doubt going to be life-saving. And Dr. Effinger, can you expand on what you were just saying? I'd love to get to know what your insights or best practices are at your institution about how you are more specifically coordinating with these other specialties and settings.
Yeah, I think, as I said, we've really worked on our transition of care process, but one thing that has been key for us is we have a nurse navigator now who has been absolutely crucial in helping us for those very complex patients, make sure that they get in to all of those subspecialties where we're referring them. We have a very strong multidisciplinary clinic with an endocrinologist and psychologist and cancer geneticist all in our clinic, and we have very close collaborations, which have been really key for us, finding somebody within oncology to be our cardio-oncology person, finding somebody within pulmonary to be our pulmonary oncology advocate, but really shoring up all of that. But that nurse navigator has been really key to making sure that our patients get where they need to get, because a lot of the, especially young patients or patients whose families may have low health literacy, it's very, very challenging to get them everywhere that they need to go.
Yeah, I imagine that healthcare hospital wayfinding is a common issue for a lot of patients. And I mean, even for myself, it can get very, very complex and confusing. So having a nurse navigator, I imagine, is a game changer for so many of these patients and their families. Dr. Armstrong, Dr. Schlotzsik-Satha?
Well, I'll add on, Karen is just talking about how to navigate them through the current system when they're still children or adolescents and beginning that transition. But after they transition, it's really the same idea. We really need adult providers who understand the needs of survivors of childhood cancer, that their radar goes off when they hear that this patient actually had cancer and might have had cytotoxic chemotherapy or radiation to some portion of their body, and was willing to ask those next level questions. And here's what happens when that doesn't happen. When a 30 or 40-year-old has high blood pressure, that's important for anybody. But we know for a survivor of childhood cancer, that can actually potentiate their risk for heart failure due to the chemo that we've given them, right? So for us, it's all important, but for a survivor, it's multiplicatively important. It's actually more important because they've already taken a first hit to their heart with some of the radiation and chemotherapy. Now the high blood pressure is a second hit. It's not the first hit. And so for a provider, a cardiologist or primary care provider to understand, hey, that's not just high blood pressure in any old body. That's a high blood pressure in a survivor, and that's a different thing. And so that's key. And so the rise of other fields like cardio-oncology is helping to educate large swaths of adult providers, at least cardiologists, who now have a sense and get some training in long-term survivorship.
Yeah, I think it's essential, and I think having a navigator is really helpful. This is what I see in our experience as well. Somebody who is additional layer of support and advocate for those patients, but also forming strong partnership relationships with our primary care providers is, in my opinion, is critical. We partner with family medicine, and actually at UT Southwestern, we even developed a fellowship training for family medicine providers who are interested in survivorship care, so they have good understanding and know how to find resources, know how to advocate for those patients and recognize those unique challenges, like Greg mentioned, that are specific and unique for our survivors. So this is essential because as patients transition, we like to see them as much as we possibly can and hold on to them, but unfortunately, reality is that they have to go to adult medicine, and finding partners on adult side is critical. Those who are interested in this specific patient population, those who recognize their unique challenges, those who are able to access and learn guideline supported care is essential. So I think education and partnership with primary care providers is one of the keys to success to help and take care of a growing population of childhood cancer survivors and overall cancer survivors.
Obviously, that care coordination and working with other colleagues in different specialties over their lifespan and lifetime is such a critical aspect of making sure that they can live long, healthy lives. What challenges have you faced in working with other disciplines and other specialties? Have there been any bumps in the road in terms of educating them or communicating with them?
I think finding champions, like Karen mentioned, in corresponding specialties is a key because we are seeing, especially in pediatrics, there are a lack of providers in some specific specialties. Like it's hard to find an endocrinologist who is invested in survivorship care sometimes. We were lucky to find partners in cardiology to help and build our cardio-oncology clinic. And that was exciting. And key to that success was really finding a champion in a corresponding field who's invested in this patient population, who recognize those issues, who have energy, and more importantly, time to dedicate to building something that is beyond the regular care and finding partners and finding champions in corresponding specialty, in my opinion, is really important.
I think one of the challenges is also, trying to make sure that these providers really understand. And I think survivorship care plans have been very, very helpful for that. So I've had patients who've said, my cardiologist doesn't think I need an echo, like they don't understand why I need it, or I can't convince somebody that I need my thyroid, checked every year. And so one of the things that we've been working on is really trying to help to automate the survivorship care plans, but also working with Passport for Care, which is an organization that takes the Children's Oncology Group guidelines and helps to generate survivorship care plans. And then with SurvivorLink as well, which is, as I mentioned, something that we developed here to help for our patients to store them there and to have them be able to access these care plans that tell them what they need. I think a lot of the studies that we've been looking at are how do we best get that care plan information to providers so that they know that this is the screening that the patients need, because it's been a challenge, especially in that transition to adulthood, like Greg was mentioning earlier.
We do feel like the care plan is great because wouldn't a physician want to receive or a care provider receive, hey, here's the script, here's what you do. The research supports that in some situations it works and sometimes it doesn't. So it's a mixed bag, but we all believe that clinicians out there are better off with a script and a plan that has come from experts.
What I'm curious, when you were starting your careers and as research clinician, did you realize that the goal would change from not just making your patients cancer free, it's now to making sure that they live long, healthy lives and in terms of everything else, transition, care coordination, and making sure that they are that they have good mental health support, that they have good fertility preservation support and are eating well. I mean, it must be very exciting to be still, even with all these challenges, to still be working with all of these different disciplines and specialties to help them navigate that care throughout the rest of their lives.
Well, I don't know if we anticipated or not, but we should have. And it's happening again right in front of our eyes because we now have our first wave of children that are becoming long-term survivors of newer therapies like immunotherapies and CAR T cell therapies and targeted therapies. And we've now got to learn again, much like we learned 30 years ago, what are the long-term effects of these. So we're actually going to go back to the beginning in some ways and start learning about from our earliest survivors what the new survivorship looks like and with contemporary therapy. So that'll be exciting too.
Absolutely. I think this topic of survivorship often reminds me of a time when a cancer patient I was talking to, she was about to undergo an extensive radical surgery. She once said to me, "What is life without quality?" And to that point, as you all have noted, ensuring quality of life simply, it means more than simply curing cancer, as you all are, doing and striving for. So how can we best support survivors and healthy behaviors? Dr. Slava, this is pointed to you, like nutrition, exercise, sleep, substance use and abuse, as you had mentioned, as part of this coordinated effort to ensure long, healthy lives beyond their cancer.
I think it all starts with education, and I'm curious what Karen wants to add to this. I think it starts with education with the counseling regarding their late effects, but also being realistic about expectations, presenting to them realistic recommendations and supporting them through those expectations. And counseling in that area is can be sensitive to patients. And when we talk to young adults, excuse me, adolescents, if you present to them unrealistic expectations, most likely they're not going to follow through those recommendations. I think bringing this information to their own level is important, and celebrating small victories with them, and obviously partnering with corresponding fields, like, for example, nutrition clinic, to help them achieve their goals. I think this is where you would start. And Karen, what are your thoughts on this?
Yeah, I think I smile because I think Shanley, one of the question that you asked Greg, I think about when I talk to the fellows, when I was drawn to pediatric hematology oncology because of like the acuity of care and taking care of the whole body. And I really disliked actually like my primary care setting when I was in training. But I feel like I do so much primary care now because it's all of this preventative work. And I think really something that Senya said really strikes home for me is really setting these realistic expectations. And I tell patients, like, you're not going to go run a marathon. Like I'm not going to go run a marathon. So what can we do to help you and to bring it, to get you excited about things? And especially, I talk a lot to young patients, it's really hard to change what you're doing at 8, but it's harder at 18 and 28 and 48. So we know that it's important for all of ourselves, but it's even more important for our survivors, kind of like what Greg was talking about with the blood pressure issues. And I think there's a lot more research to be done. A lot of people are now trying to modify some interventions that have been developed for the general population, but really bringing that cancer survivorship piece in, because we know our patients are different. And there's a lot more work to be done with substance use and abuse, because that's an area we're just kind of starting to touch on. Most places, if you have to do reporting for opioid use, history of cancer, you don't have to like check the registries. But some of our patients continue to have problems with that when they come off therapy, and trying better ways for chronic pain management is important.
And maybe I'll round out this discussion with a totally different angle, because I agree completely with Sinya and Karen. But another area that I think we could do more effort in is policy and changing policies. When you start thinking about policies for survivors, it really narrows our thoughts, because we want everything, right? We want a survivor to have their survivorship care plan and get everything. But the reality is we may need to help focus. And one area of focus would be second cancers. It's really hard to fathom that these survivors beat one cancer and then they're at higher risk for getting another one because of the treatments we've given them. So we do have guidelines that prescribe screening for breast cancer early, colorectal cancer early. But can we develop policies that incentivize these screenings actually getting done at a high rate in this high risk population? And so that actually could be a game changer, is to have a policy that way. And so we've done a little work here looking at those two, and identified that if, let's say, Medicare covered screening for those two cancers, breast and colorectal cancer, we would save hundreds of billions of dollars in the United States in downstream costs. And so putting that, Matt Earhart has led that work here. We want to put that in the public space in the next few months, and maybe help it focus in areas where we can change policy that would really change care for kids.
Yeah, Greg,
Absolutely. Oh, go on.
I was gonna say, Greg, I think that's so important. And I think that like plays back into the financial toxicity. Like a lot of our patients are really willing to do some of the screening, but it's just cost prohibitive. I mean, a breast MRI, even with good insurance, can still be thousands of dollars. And it's a lot. Our echocardiograms are a lot, but we know that we have the data that it can really change lives.
And the data is shocking, because 1 in 3 women age 50 who's a survivor of childhood cancer who had chest radiation as a child will have breast cancer. So by age 50, 1 in 3, that's like having a genetic family at risk for breast cancer. It's a really high risk. And so why are only a third of women getting their breast cancer screening? Well, Karen's told you. And so these are areas of focus that really could change care for the next generation if we can do it.
Absolutely. So it definitely sounds like not only is it about supporting these healthy behaviors, it's about having the policy to help support them and help encourage them to get their screenings. So it's a very, very holistic approach, sounds like. That's very exciting. I think the other component that I know is very critical here is that fertility preservation is something that we had talked about very briefly as well, but I definitely want to unpack that and spend a little more time talking about this topic because pediatric patients are at, as you all had mentioned, at a higher risk of developing infertility due to their cancer treatments. But thanks to modern medicine and less stigma around talking about fertility with children, fertility preservation has emerged as such a critical and important topic to discuss with patients before they undergo treatment. Dr. Schlotzsava, I understand that this is an area, a topic that you're particularly passionate about. So I'd love for you to start us off here. What can you tell us about these efforts in fertility preservation and how is it helping cancer patients and survivors?
Yeah, with absolute pleasure. So this is definitely something I'm passionate about. Pediatric fertility preservation really works best when it's approached systematically. It has to be tailored to individual patient needs. In my opinion, every child, adolescent, or young adult who are facing treatment that can be potentially gonadotoxic should have infertility risk assessment at the time of diagnosis, followed by a developmentally appropriate discussion about the risk. In some cases, the risk is low, and reassurance alone can be incredibly meaningful for patients and families. When I talk to families during their state of crisis at the time of diagnosis, they actually perk up and say that you actually truly believe that my child is going to survive. That's why you're thinking about their future. It really highlights how important those discussions are for families, and they actually can handle those discussions at the time of crisis during their diagnosis. And obviously, when the risk is higher, patients should have an opportunity to consider fertility preservation options. That requires a multidisciplinary approach, particularly in pediatrics, where age, pubertal status, sex, and time constraints all influence what options are feasible for patients. It is essential that we offer the full range of fertility preservation strategies so care can be individualized. And this conversation should not end with treatment. Revisiting fertility and reproductive health during survivorship is critical. Especially, there might be a second opportunities for patients to consider, especially for female patients, to consider fertility preservation. Many of our patients are diagnosed at a young age, and as we discussed, may not remember their cancer treatment and cancer journey at the time, making survivorship education and ongoing counseling essential to inform decision making later in life. And as Karen and Greg mentioned about policy and advocacy, importance of policy and advocacy in survivorship space, it is something that is relevant and important for fertility preservation as well. For example, in Texas, patients with care have access to fertility preservation because of the mandate that was passed in 2023. And in many states, there's ongoing advocacy efforts to enable patients to have access to this care. And it's even more difficult without those efforts. And I think we need to advocate for our patients and families on much larger scale so they have quality life in survivorship.
Yeah, I very much agree with that. I think this is a huge space for advocacy and more education and research into the best methods for educating into the survivorship space. And I agree with Senya, like this needs to be addressed up front, obviously, but it's really important in survivorship and helping people get the fertility assessments that they need if they're interested in knowing where they stand to get that data and to support them financially in doing so. Because again, it's just another expense, but it's one of the top three things that survivors are worried about. They're worried about relapse, secondary malignancies, and they're whether or not they're going to be able to have children.
Yeah, I understand. I mean, you had talked about the financial toxicity of it, but to Dr. Slav's point, I imagine, the families are very excited when they hear that this is an opportunity, that you think that they'll be able to have a family later on down the line. So a very, very important topic to discuss with your families. I wonder, in the field of oncofertility preservation, how has the conversation changed since, say, 10 years ago, 5, 10, 15 years ago?
It definitely evolved, and I think having access to fertility preservation options such as ovarian tissue cryopreservation and having access to experimental methods such as testicular tissue cryopreservation under IRB approved protocols did change the landscape because previously we would have a discussion with families, and unfortunately will have very limited options available to them, especially for young patients who are still going through pubertal development. And having those options available, obviously with all the nuances that we know that we're still learning from research, having those options available is critical. And hopefully there will be more hope and more research that is done in this space that proves the ability to restore fertility from previously frozen testicular tissue, for example. So this is definitely a rapidly evolving field currently, and taking an opportunity and getting this research, which maybe 10, 15 years ago felt like science fiction, is really exciting that we bring this to bedside currently. And hopefully research will continue in the space of fertility preservation and also advances in reproductive health that our patients can benefit from down the road. I think this is critical. I think it highlights how those things can come together from the research and clinical care standpoint. And this is critical to help our patients from that.
Absolutely. Absolutely. Dr. Armstrong, was there anything you wanted to add on this subject?
No, this is actually an area where we've made headway with policy. I mean, just last year, I think 21 states now expect support for these early fertility conversations and options for preserving tissue. And so that's where policy may make a big difference. Maybe the other thing to say to those who may not be in an academic center is one of the hardest things when there's a kid newly diagnosed with cancer is to pause long enough to have this conversation about fertility, because there's a sense of, let's get the chemotherapy going, let's get the radiation going, let's go, let's go. But it is worth the pause to have this conversation and to make a plan.
Absolutely. Shifting gears a little bit here, I know that one of the challenges that you all had mentioned too was access, and you all represent some of the nation's best children's hospitals for cancer, according to US News. So how are you ensuring that your life-saving care, whether it's fertility preservation and cancer care and ensuring the quality of life, how are you making sure that it reaches patients who live outside of Dallas, Atlanta, and Memphis?
Well, I will start here. We address this through multiple strategies, including telehealth visits whenever it's appropriate and possible, with close coordination with local providers, and ensuring that we deliver risk-based care to our patients that allows patients to receive appropriate aspects of care closer to their home. One of the examples that we're lucky to have is Moncrief Cancer Center that we have here, which has a strong track record of delivering cancer care and survivorship services within the community. And this type of collaboration allows us to extend specialty expertise beyond Dallas while maintaining continuity and quality of care. And I think additional resources such as social work or care coordination with the navigator and community partnership are essential in supporting families with logistics such as travel, housing, and insurance. So I think this is what we try to achieve here. But I think I agree with you. This is definitely a significant challenge that we're all facing.
And I'll speak from more of a research end. We want research to be translated not just to the country, but to the world. And so one of the ways is by letting this research knowledge be translated into guidelines. You've heard that word a lot, but the Children's Oncology Group has a set of guidelines for recommendations for long-term follow-up of survivors and adolescents of cancer. But you've got to get those out. You've got to disseminate those. So Matt Earhart and Danielle Friedman, Matt is at St. Jude, Danielle at Sloan Kettering, are working together as the COG guideline leaders. We're now building those out into a platform that will be a global platform that will actually provide resource adapted guidelines so that if you're in a lower middle income country, you can see what the guidelines would recommend, but if you can't provide them, what would be the next level of guideline care you could provide given the resources that you have. So doing that to try to get the knowledge out there more broadly, but also to resource limited settings.
I was going to echo what both Sonia and Greg said. I think using locally resource networks is really important, and then also implementation science for the different initiatives that are going on. So we've currently been able to start doing depression and anxiety screening using promise measures in our clinic, and it's built into Epic. And our goal is then to spread this out to other places and to use local initiatives that have worked well, and how do we spread it to other survivors. And I think the survivorship community is as small and tight knit, and we're always willing to learn from each other.
Absolutely. You all have mentioned too that policy could absolutely help scale the efforts that you all are having and are making at each of your respective institutions. My question in terms of policy, we've talked about it from a fertility preservation standpoint, from screening guidelines. What would be your policy wish list? Any efforts that you'd like to flag that have been successful on the policy front, at whether it's the state or federal levels, that are worth replicating or scaling?
Yeah, I've stated mine, so I won't spend long, but it'd be cancer screening and cardiac screening, right? Those are screening, there are subsets of survivors who are high risk for these outcomes. There's guideline-based recommended screening, but less than a third of children are getting them as they leave their institutions. So I don't mean in their children's hospitals. I mean, when they go beyond and leave their children's hospitals, making sure that there are policies there to help support them getting their cancer and cardiac screenings.
I think
I
for
would
me, oh, go ahead.
Go ahead, Karen. Go ahead, Karen, and I'll add.
I think for me, insurance reimbursement for adult providers, so that, I think that there are different metrics that people have for their diabetics if you do all these things. So if you could get reimbursed, specific guidelines for, hey, your survivor got their echo that they were supposed to get, but also increased reimbursement for the care. Because as we've all said, there's a lot of care coordination. These are not the typical 30-year-olds. Like, a PCP has so little time to see their patients, and you can see 3 or 4 very healthy 30-year-olds in the time it takes for one survivor who may not even be our highest risk survivor. And so I think policy to change that would be huge.
Yeah, I would like to echo Greg's and Karen points. I think ensuring guideline supported screening for patients and make sure that it's all covered and reimbursed. As an anecdotal example, we even had orders blocked in Epic previously, saying that patient does not meet age parameters for the order for screening, and overcoming those. It sounds silly and simple, but that's something that makes care even more challenging. So overcoming those with policies and procedures that allow you to deliver what is right, what is important, what is research driven care is essential. And I think we need to start small and expand beyond that and advocate for those patients.
Absolutely. I love what Dr. Armstrong, what you said very, very early on in our conversation. And I kind of want to bring it back to that, about how the successes you've made and the efforts that you've made in pediatric oncology are like the headlights on the car. I'm curious, with the 85% survival rate in children cancer survival rates, what can adult oncology learn from this pediatric model of care?
Yeah, I might defer to Karen and Cinya. That's a hard question. I'm going to punt for a second and see what they say.
I think collaboration, one of the big things that has been able to drive our numbers, partially because we're a small community, is the Children's Oncology Group coming and bringing research together to many, many different providers. And almost every pediatric center across the country, you will get fairly standardized treatment for your patient. And that has done a lot to move the needle for survivorship. And I think that's what's needed on the adult side, but also looking at the whole patient and remembering long-term effects. So I have a family member who was treated for a cancer in her 30s, and I have been her survivor provider. I have been the one and I'm much younger, that has been like, oh, well, of course this is going to happen. You had X, Y, and Z. And so I think remembering that even patients who might be in their 40s or 50s when they're treated are hoping for many decades of life after that, and really learning from them, having things like what Greg has been able to achieve with the childhood cancer survivor study, but things that we know we need to watch in our adults as well.
Yeah, and I would like to absolutely echo that. So I think survivorship must be treated as an essential part of cancer care. It's not an optional add-on. And this is, as pediatric providers, this is what we think from the very beginning about, and not always for adult providers. This is the mindset that is in place. And this means planning early, working collaboratively across disciplines, and investing in systems and supporting survivors across their lifespan. Like Karen said, that thinking about this patient as a whole and thinking about all those years beyond treatment is essential. This is when you start recognizing and educating patients in the beginning about late effects. This is when you start thinking about their psychosocial developmental aspects that can be affected by cancer care. This is when you start thinking about implications of financial toxicity currently and down the road, and really putting this as a treating patient as a whole. This is when you can make the most impact, and collaborating with other providers, researchers, policymakers, and healthcare systems. I think this is where the golden egg is.
Yeah, now having had some time to think about it, that comment about the headlights in the car was really that it's our early research. We started doing research in survivors of childhood cancer decades ago, and it shone a light not only on the late effects of our survivors of childhood cancer, but it really gave adult survivors of adult cancer clues about how their patients are going to do over decades. And so I guess what I would come back to and say that the research has always been the headlights on the car. I've got to advocate that in addition to great clinical care, we need to be collecting data. And maybe that gets easier in the coming decades with EHRs and large data sets, but we have to continue to learn.
Absolutely, absolutely. And so before we wrap up, I do have a couple of questions from our audience. We've covered a lot of incredible topics today, but we do have some questions from our audience that I'd like to give voice to. The first one is an electronic records. The recommendations in education should consistently be documented as a first line of advocacy for the patient when older, something that follows them, empowering the patient. Is that the case, or is that becoming the case?
I think that, yes, go
Go
ahead,
ahead,
Karen.
Cindy. Yeah, you got it. Go for it.
I think that's something that has to happen. All this should be documented in their primary electronic health record system. And ideally, you should have access to a treatment summary that may be easier to generate with leveraging electronic health record system, and with some additional information that helps to guide the care. So I think it's essential to have this information documented, even flagging for provider when patient comes in with symptoms to suspect cardiac failure. It would be important and essential piece of information to know that those patients maybe also received anthracyclines in the past. So I think it's essential. But Karen, go ahead. And I think you had some thoughts on this as well.
Yeah, no, I agree. I think that is what we are moving towards and what we need to move towards. And it's interesting, there's been many studies, but also just anecdotally looking at records, patients don't always tell their providers they had cancer. That is not something that it's in their rearview mirror, so they don't feel like it's important. And so making sure that even something as simple as their history of their medical problems gets into the documentation. And it's challenging. It's gotten better through some of the care coordination with the electronic health systems, but we're still not there.
I agree.
The second question that I have from one of our audience members is, how can we work better with advocacy groups to connect cancer patients and survivors with clinical trials? Any big picture ideas?
Well, it starts by listening. We really, especially on the research end, we need to listen and listen to what matters to patients and listen to their voice. And, it's changed how we've done research. Now, when I put out a new invite for a certain research topic, I'll have an ambassador letter right there on top of the packet. The first thing a new participant might see is that someone like them has been down the same road and is recommending that you consider enrolling in this research because it will shine a light on things.
I think we need to be better about using our advocacy organizations and really leveraging them. And for all of us, realizing that even though we were once those young adults, we aren't anymore. And so that we need to do what Greg said and listen to our patients and the young adults and see what speaks to them, and know that our enrollment methods may be different in our research because we aren't the paper and pencil people with the Scantron bubbles that we used to be.
Yeah, I absolutely agree with that. I think listening and hearing them as a first step, and really getting connected better with advocacy groups and organizations to help patients.
Wonderful, wonderful. Well, you have all shared so much insight, so thank you so much. My last question for you, any final takeaways or calls to action for those in our audience, both in the healthcare community, family members, and anyone beyond that?
I'll just go back to responsibility. It is our responsibility. The cost of inaction is too high. The cost of not taking care of survivors is too high, and our healthcare system is too high for those individuals. So I think we just have to each know it's our responsibility in our healthcare systems to care for this population.
Yeah, I absolutely agree with that. I think it's our responsibility to help navigate through cancer treatment, but also survivorship for our patients. And as I said early, that this is an essential part of cancer care. This is not an optional add-on, so it has to be embedded, incorporated from the very beginning.
I think one of my favorite quotes from a paper that was published in the 1970s is "Cure is not enough." And I think that is what guides me and needs to guide our healthcare system, is that while that is our goal and we can't have survivorship without cure, the cure itself is not enough, and we need to continue to support our survivors and help to give them the resiliency that they need to live these long, thriving lives.
Amazing. On that note, I'd like to wrap everyone up. Unfortunately, that is all the time we have for today. So I want to thank each and every one of you for your time and your insights. And I want to thank everyone in our audience for joining us for today's discussion. A recording of this event will be shared in the coming days. And please don't forget to visit usnews.com/events for information on upcoming events from US News, including the return of our in-person Healthcare of Tomorrow in DC this June. Look for details about registration for that conference very soon. You can also find a wealth of content, rankings, and other insights from our health team at usnews.com/health.